I'm curious, there's something that you have talked about, you've done a lot of work on this. And I love the concept of moving from fee for service to more of this bundled code, or essentially going for diagnoses instead of the actual procedure. Right.
Yeah.
Reimbursing for diagnoses. And I want you to talk about a little bit of this. I think it's a fantastic topic.
So I think for people who don't know, like the label that's most often applied to the dominant reimbursement model for physicians or any care providers in the US is fee for service, which means that you do a activity and you get paid for it. The more complex the activity, or the more of that activity you do, the more you get paid. And so that works in certain situations and in certain, in other fields outside of healthcare. Like if you own a car dealership, the more cars you sell, the more money you make. That's fine. But the question becomes in healthcare is like, what are we trying to optimize for, right? It's not that the healthcare system is best that does the most things, right? Like it's not that if you were to rank every country's healthcare system, that you would say the number one country is the healthcare system that's the busiest, that's doing the most things, right?
It's almost the opposite, right?
Totally. It's actually, and that the joke about is it a sick care system versus a healthcare system is that what you want is patients to be healthy and for outcomes to be good at the lowest cost possible, because we're all paying into this system. And so that's where the term value comes across, of course, and it's like a totally overused term. But really, value is outcomes achieved per dollar spent.
I've got your quote on my page. And I was like, he's going to beat me to it. He's going to beat me to it.
Outcomes achieved per dollar spent. So, and then the question we have to ask ourselves is the current healthcare system in our country, the marketplace, if you will, competing on value? And we're not competing on value. We're competing on all sorts of other things, but not value, except for there are like pockets where that exists. But in the sort of dominant aspect of all American healthcare, we're not competing on value. And so then you ask the question, like, what would that look like? And this is why the cost analytics stuff, I think that we started to do is important. And I'll just give you an example, which is take a patient that has a cervical radiculopathy. They have arm pain shooting down their left arm. They've tried all the conservative things. They've tried injections, physical therapy. MRI shows they have a disc herniation at C5-6, and their quality of life is really affected. They're not working anymore, and they're ready to get something done surgical, and they're a good surgical candidate. And they go to see a surgeon, Surgeon X, and the surgeon recommends an ACDF, anterior cervical discectomy and fusion, a perfectly reasonable operation for this problem. But say it turns out that this patient is in that subset that would also be a candidate for what's called a foraminotomy, which essentially is a clean-out procedure. It's a decompression that doesn't involve putting any implants in. Sure. Not every patient with a cervical radiculopathy is a candidate, but some are. And say this patient happens to be one of those patients. And they go to Surgeon Y. And Surgeon Y says, hey, look, I think we can get you better with this foraminotomy. You don't have to put any metal. We don't have to put any metal in your neck. It doesn't mean it's your last operation, but I think it's the least invasive thing for you. And then let's fast forward in these two parallel universes where this patient got an ACDF in one universe and he got the foraminotomy in the other universe. And we compare the two. Let's say the outcomes were the same. Two good operations with the right indications. But let's look at the costs, right? And what I mean by costs is costs to the patient, costs to the hospital, and costs to the payer. On all three, the hospital costs are less because they didn't have to put any implants in. The payment to the payer is less, and therefore whatever out-of-pocket expense to the patient is inevitably going to be less. And because the recovery time is less, they might go back to work faster, which means the costs on society and the cost to the employer is less. So I think for the right indication, the foraminotomy is the better option for everyone involved, right? But if you don't measure the costs in addition to the outcomes together, you wouldn't appreciate the fact that the foraminotomy is better. In fact, if you're looking at something like RVUs, relative value units, or revenue for the hospital, the ACDF looks better. And that's why I think measuring value is important, which means you have to measure the outcomes and you have to measure the costs. And it's not enough. In some places, people will take costs and as a proxy for cost, they'll look at how much the insurance company paid the hospital. But that gets into all the unique, what are the negotiated rates that this hospital has with that employer, and there's all these other confounders. But if you get down to brass tacks with what did it actually cost to execute this episode of care and merge that with the outcomes, now you're looking at value. And if you're competing on value, a lot of these weird incentives and sort of odd observations that we're making, I think would fall by the wayside.